Hi, I'm Liz Carlson, and this is my video for the physical assessment test out for 509, Physical Assessment of Nurse Anesthetist. I will be using my husband, Lucas Carlson, as my patient today, and will just be ad-libbing if I have equipment that I don't have in the condo. We're going to begin with a neuro assessment. Can you please answer a few questions for me? What is your name?
Lucas Carlson.
Where are we?
We're in our condo in Niles.
What year is it?
2025.
And what are we doing here today?
We are filming your physical assessment video for class.
Perfect. Patient is ANO times 4, no deficits noted. Moving on, we're going to be testing his cranial nerves 1 through 12, beginning with olfactory cranial nerve 1. We're going to be testing his sense of smell with olfactory nerve. Please go ahead and close your eyes for me and occlude one nostril. I'm going to have you sniff. Tell me what you smell.
Mint.
Beautiful. Go ahead and occlude the other nostril and tell me what you smell.
Cinnamon.
Perfect. Cranial nerve 1 is intact. Moving on, we're going to be testing cranial nerve 2, which is the optic nerve. We have 3 ways to test this nerve: visual acuity, visual fields, and the optic fundi. For visual acuity, we're going to be testing his clarity of vision. We don't have a Snellen chart here, but I'm going to talk through it. I would have the patient stand 20 feet away from the Snellen chart and tell me what line he could read the smallest. If he were to have contacts or glasses, I would allow him to wear them during the test. And then for better accuracy, he could also cover one eye and do the test as well. To test his visual fields, we will test for periphery. So we're going to be using the confrontation test. This can either be done with the wiggle finger test or with showing numbers. So what I'm going to have you do is swing your legs around. You're going to get about 2 feet away from your patient, have him close one eye, and I'm going to close the same eye. And you're going to tell me when and what numbers you see.
1, 2, 3.
Go ahead and do the other eye.
4, 2, 1.
Perfect. And then lastly, I'm going to pretend that this is an ophthalmoscope and I'm going to be testing the optic fundi. With this, I am looking for discs, vessels, retina, and things like that, the internal structures of the eye. So what I would do is I'd get very close to the patient and use my eye and make sure that the red reflex is present bilaterally. I'm also looking that the discs are bright yellow, a good border, well delineated. Moving on, I would see that all the vessels are intact in both eyes, and then finally I would see that the retina is uniform in color without any lesions. Grouping together cranial nerves 2 and 3, we're going to be testing the pupillary light reflex. With this, we're testing PERLA, so pupils are equal, reactive, round to light, and accommodative. For the first part of PERLA, I'm going to be using my pen lights. We're going to be looking straight at me or just a little past, and I will shine a light in your eye. Great. And then finally, I'm going to have you follow the pen light with just your eyes. Perfect. Pupils converge in and the pupils also constrict, so it is appropriately intact. Moving on, we are going to be testing cranial nerves 3, 4, and 6. 3 is oculomotor, 4 is trochlear, and 6 is abducens. With this, we're going to be testing the extraocular movements. I'm going to be doing the 6 cardinal gazes, so keeping your head straight and just moving your eyes, you're going to follow my finger. Perfect. All 6 cardinal gazes are intact. Normally you want to do either an H or a star for that one. And then the cranial nerve 3 does kind of all the motions. Cranial nerve 4 does downward and internal. And then the cranial nerve 6, the abducens, does the lateral deviation of the eye. Moving on, we're going to be testing cranial nerve 5, which is the trigeminal. So I'm going to go ahead and use my cotton ball for this. We're going to be doing 2 tests. 1 is sensory and 1 is motor. For the sensory, I'm going to be doing 3 areas. We're going to be doing the ophthalmic, so somewhere around the eye, maxillary around the cheek area, and then mandibular around the chin. I'm going to have you close your eyes and tell me when you feel.
I feel it. I feel it. I feel it.
And then we're going to do bilateral.
I feel it. I feel it. I feel it.
Perfect. And then for motor, we're going to be checking his masseter muscle, so the muscle of the jaw. I'm going to have you clench your teeth and don't let me move. Okay, unclench and clench. Perfect. Go ahead and move your jaw side to side. And I noticed that sensory and motor function for cranial nerve 5, are intact. Another way to test cranial nerve 5 is bringing it in with cranial nerve 7. So 5 is trigeminal and 7 is facial. So for this one, I'm going to use my cotton swab again and test his corneal reflex. So with this, we should be seeing a blink once I touch his cornea. Great. Moving on, we're testing cranial nerve 7, which is the facial nerve. This is going to run through all of the facial muscles. So I'm going to have you elevate your eyebrows, Raise your eyebrows, perfect. Puff out your cheeks. Perfect, smile. Show me your top, bottom teeth. Perfect. Squeeze your eyes really tight and don't let me open them. Great, cranial nerve 7 is intact. Another part of cranial nerve 7 is that the anterior 2/3 of his tongue would do sweet and sour taste sensation. Moving on to cranial nerve 8, this is the vestibular cochlear, also known as acoustic. This is going to be doing hearing and balance. This is going to be my tuning fork today. We do not have one in this condo, but first to test gross hearing, I'm going to have you cover one ear, and we're going to perform the whisper test. You're going to just repeat what I say to you.
45, 22, 3,
Switch ears, please.
2, 22, 75.
Perfect. Since gross hearing is intact, you don't have to continue with any more tests. But for this exam purpose, I'm going to go ahead and do the Rene test and the Weber test. First is the Weber, so right in the middle of his head, and he's going to tell me if he hears it louder on one side or not, or just all over. And this is for lateralization. So strike the tuning fork and tell me where you hear it.
I can hear it all over.
Perfect. And then next is the Rene test, and how this one is done is you strike it, put it on his bone, the mastoid process, and then remove it once he stops hearing it and see if he can still hear it.
I can hear it. I can hear it.
Okay, so once he stopped hearing it and I took it off, air conduction is longer than bone conduction, so that is normal and intact. Moving on, we're testing cranial nerves 9 and 10. This is the glossopharyngeal and the vagus, and this is going to be swallowing and palatal movement. So with this, I'm going to be using my pen light just to see in the back of his throat. I'm going to have you open your mouth, stick out your tongue, and say ah.
Ah.
Perfect. I see the uvula rise and fall midline, no deviations, and the soft and hard palate are intact and present as well. Another thing to do for this exam with the cranial nerves 9 and 10 would be a gag reflex. Since he's healthy, awake, and alert, I'm not going to stick something down his throat. But what you would do is you would take a tongue depressor and stick back and see for the gag reflex. Moving on, another test that you could group together would be cranial nerves 5, 7, 10, and 12, and this would be voice and speech. I've heard him talk, no articulation issues and no concerns that I have, so I would have no further testing. And then moving on to cranial nerve 11 is the spinal accessory nerve. What we're going to be doing is testing his trapezius and his sternocleidomastoid. So we're going to be doing two things. One is having him shrug his shoulders against my resistance. Perfect. And then one is moving his face against my hand for head rotation. Everything is intact. And then lastly is the hypoglossal nerve. This is going to test for tongue symmetry, position, and movement. You can maybe stick your tongue out at me. Move it side to side. Perfect. Everything is intact with the cranial nerves. Moving along for the primary sensory function of the test, we're going to be doing the gait part of the test. I'm going to have to go ahead and stand up. And just to test his overall gait, the patient is going to just walk back and forth, just once there and back. And I'm noticing his position and if he has any stumbles or things like that. And there's no issues. His gait is smooth, effortless, easy, no problems. For balance, you could also test this with cranial nerve 8 for the Romberg test. I'm going to have you go ahead and close your eyes. I would put my hands out for support. What you're watching for the Romberg test is any sways or movements like this. You'd watch for 20 to 30 seconds for the purpose of this video. We're going to be done. Everything is negative, which is a normal Romberg test. And before I have you sit, I'm going to have you do the pronator drift. With this, I'm going to have you stick out your arms supine, palms up to the sky. And I would watch again for 10 to 20 seconds. What you're looking for a pronator drift is one arm to kind of drift down, and that'd be a sign of cranial nerve damage. Everything is appropriate and intact. We're also going to do accuracy of movement, so I'm going to have you go ahead and sit and face me again. With this, it's going to be the finger to nose test, making sure that he can actually follow my finger. So you're going to go ahead and touch your nose on my finger, nose to finger. Perfect. I'm going to move. Perfect. Great. Next, we are going to be doing rapid alternating movements just to see that it's intact as well. Hands on your thighs, and you're just going to go back and forth. Perfect. Everything is intact there. Moving on, we're going to be doing primary sensory testing. With this, we're going to start with superficial touch. Again, using a cotton swab, and instead of just a space, we're going to be doing body, so I could touch your arms, your legs, or your face with this. You're going to close your eyes and tell me when you feel it.
I feel it. I can feel it. I feel it. I feel it. I feel it.
Great. And then we're going to be doing superficial pain. With this, I just have kind kind of can see an unwound paper clip. I'm going to show the patient that this means dull and this means sharp. You're going to close your eyes. I'm not going to do anything too hard, but tell me what you feel, sharp or dull.
Dull. Sharp.
Okay.
Dull. Sharp. Sharp.
Good job. Next, we will be doing, it calls for deep pressure, but since everything beforehand is intact for him, he doesn't need deep pressure or temperature check, but that would be how you proceed with the further testing. Next, I'm going to get my tuning fork back. It's just my marker since I don't have one. And I'll be doing vibration. All you do is hit your tuning fork and hit it over the bony prominences. I will be doing his elbows, knees. You could do like shoulders, hips, things like that. You're going to tell me when you feel it.
I feel it. I feel it. I feel it. I feel it.
Great. And then next up, we are going to be doing joint position or the proprioception. You could either use a big toe or a hand. Just for the filming purposes, I'm going to be using an index finger. And what I would do is I would have him with his eyes open. I'm going to move his index finger up or down, and he's going to tell me which I'm doing. First, you can see this is up, this is down. Go ahead and close your eyes.
Up, up, down.
Okay. Do everything bilaterally, so up and down again.
Up, up, down.
Perfect. Moving away from primary sensory, and now we're going into primary cortical. We're going to be doing stereognosis, however you say that, and we're going to be doing object identity. So I'm going to be getting a few objects, and I'm going to have you close your eyes. Nothing is sharp, nothing is going to hurt you. Open up your hands. I'm going to give you one object at a time, and you're going to tell me what it is.
It's a paperclip.
Great job. And then number 2.
That's a pen.
Perfect. Next test is going to be the graphesthesia. I'm going to use the pen. It's going to be closed. What I'm going to do is I'm going to write a number on your hand, and you're going to tell me what it is. Eyes closed.
3.
Great. And this one.
M.
Good job. Next up, we're going to be doing the 2-point discrimination. We are using, again, the unwound paper clip, and I'm going to show you with your eyes open. This is 1, and this is 2. Okay, go ahead and close your eyes.
1, 2, 1.
Good job. And they also say that the best place to do this is the fingertip. So for the other side, I'll do the fingertip.
2, 1, 2.
Beautiful. So far, everything has been intact and good. And then last would be point location. So with this, you're going to close your eyes. Wherever I point, you're going to point to it as well. Wherever I tap. Yeah, you could also vocalize it.
Shoulders.
Just for the video. Perfect.
Knee.
Perfect.
Knee. Shoulder.
Perfect. Moving on, we are going to be doing muscle strength. When we test muscle strength, we do it on a scale from 0 to 5. 5 being normal and 0 being no movement and concerning. With this, I'm going to be testing his upper and lower extremity strength. First thing I'm going to have you do is grab my hands. I'm going to try pulling away, don't let me. Perfect. And then I'm going to push, don't let me push you away. Perfect. Lower extremities, I'm going to grab behind and you're going to not let me pull you back. Perfect. And now you're going to kick out at me. And then we're going to be doing the dorsiflexion and plantar flexion. Plantar flexion for you is going to be like pumping the gas, so go ahead and press down on my hands. And then dorsiflexion is feet up. Perfect. Everything is intact and 5 out of 5. Now we're going to be moving on to our deep tendon reflexes. The tuning fork has now turned into the reflex hammer. The best way to do this for the video purpose, I feel like, would be this arm. Yeah, actually that would be a smart idea. Perfect. So there's going to be about 5 reflexes we test. Bicep, brachioradialis, tricep. Then we have the patellar and the Achilles. I'm going to go through, and I kind of told him what to do because we don't have a real tuning or reflex hammer, so he's going to act it out without being too much. But for the bicep one, what you want to do is have them be as relaxed as they can and kind of flex just a little. Sorry, not flex, perfect. And then instead of hitting his actual skin, I'm gonna, as I hold, I'm hitting over my thumb. And we'll do this, and what you should see is just a little twitch. For brachioradialis, you're gonna go down to the forearm, and what you're gonna do is same exact motion where you just hit over your thumb, and what you should see is like a little supination of the arm and a little flexion. Both bicep and brachioradialis are testing for C5 and C6. Moving up, we're going to be doing the tricep, and for this one, I'm going to go ahead and have you dead weight completely. And what you're going to do is you're going to go ahead and hit, and you'll see the little flick. Tricep is C6 and C7. Thank you. And then moving down, we're gonna do the patellar one, which is probably the most dramatic that we'll see today, but it's right under the kneecap basically, and what you do is you just strike, and the actual bottom knee will flex out. The patellar is lumbar 2, 3, and 4. And then moving on, we're gonna be doing the Achilles. For this, you don't want a lot of pressure on him, but just a little bit. And what you would do is hit right behind on the Achilles and see just a little bit of a twitch, and that does S1. Moving into superficial reflexes, I'm just gonna talk these through just because for the appropriateness of the video, we're not gonna be doing them because he's keeping his clothes on and things like that. But the first one would be upper and lower abdominal. You would basically stroke like right by his belly button and see just twitching by where you're poking, or stroking, not poking. And then for the cremasteric, however you say that, that would be the scrotal test. So you'd stroke the upper thigh and the scrotum on that side should elevate with the stroke. And then the plantar reflex, I could do this one. This is when you would actually grab his foot and stroke laterally from the side, and you should see some flexion extension, okay? Lastly, for the neuro exam is going to be for nuchal rigidity and meningeal irritation signs. So that includes nuchal rigidity, Brudzinski sign, and Koenig sign. You want these all to be negative, otherwise you would elevate testing. So first I'm going to have you for nuchal rigidity, chin to chest for neck flexion. Perfect. Any pain with that?
Okay.
Perfect. Everything is intact. He is able to do the full motion and no pain present. And then you're going to do that exact motion again. What you're looking for the Brudzinski sign is for his hips and knees to flex. That would be a positive sign for meningeal irritation. And then finally for the Koenig sign, you would have the patient lie flat. I'm gonna lift him and kind of have his knee and leg straight and knee bent a little bit. And when I stretch and bend him, there should be no resistance and no pain. Any pain or resistance?
No pain.
No resistance, felt, and no pain. Go ahead and sit up. Okay. Okay, moving on to the next exam, we're gonna do the head and neck inspection, palpation. First, I didn't say this in the last part, I'm going to do hand hygiene before every section. So I get clean, and then just looking at his head, midline, normal cephalic, symmetrical, no deformities noted, shape is atraumatic. His hair color is blonde, scalp presents to be without lesions. And then I'm gonna go into the palpation part. So I'm actually gonna touch your head. You're gonna tell me if you feel any tenderness anywhere. I'm just gonna go ahead and start from the front basically and go from the back. I would also look in his hair and see like, I don't know, infestations, bald spots, anything that would like indicate like alopecia or anything that would be abnormal. Everything is normal. His hair is soft, fine texture. I didn't feel any deformities. Was there any tenderness?
Nope.
No masses. For his face, you're just gonna look again at the general inspection. Everything is symmetrical. There are no abnormal features, no involuntary movements like a tick or anything like that. I'm gonna go ahead and palpate. I touched your head, so I do hand hygiene. I'm gonna palpate for the temporal artery. So how to find this? It's kind of like on the same level as the eye crease, and then right preauricular area, so right in front. Any tenderness when I'm palpating here?
No.
No hardness, nothing distended that I feel for the temporal artery. And then for the TMJ, you're gonna go just below it. I'm gonna go ahead and feel, and you're gonna open and close your mouth. One more time. Any pain or tenderness?
Nope.
Everything was normal. My fingers fell into the fossa. There's no crepitus or clicks noted. Another thing that we could palpate for would be the chopstick sign, and this is a sign of hypocalcemia. So what would happen is I would tap over the zygoma, and I would see a facial twitch, like hyperexcitability for the hypocalcemia. There's nothing on him, so no signs of that. Next is the salivary glands. I'm only gonna feel for 3. So I'm gonna do the parotid is first, and it's just right in front of the ears, kind of like into the chin neck area. And then I'm gonna go submandibular, which is right at the base of the neck, and then submental, that chin area. I don't feel any signs of inflammation or anything like that. Next, I'm gonna do your sinuses. So I'm gonna do is take my thumbs. I'm gonna do his maxillary, which is right under his eye, and then his frontal, which is his forehead. Tell me if you feel any pain or tenderness. Anything?
Nope.
Okay, and then the frontal.
Nothing.
Great. Okay, moving on. Now we're gonna look at the neck, overall inspection. It's symmetrical, no masses, nothing too alarming sticking out. There's no webbing or fullness at the base. His musculature and posture is appropriate for his age. his profession, his athletic day-to-day ability. And then for his jugular vein distension, I'm going to have you look a little bit up and to the side and a little less. And what I'm doing is I'm looking kind of right in front of the sternocleidomastoid, and I'm looking for any type of pulsation or any distension. It's negative on the left side. Go ahead and do the opposite for me. And then there is nothing on the right side as well. It'll be easier too when we do that abdominal assessment. We actually play him flat. Noting his trachea, you just want to see that it's midline. You want to be actually midline, middle with them. And then when I'm looking at the trachea, I notice his Adam's apple, but other than that, there's no distension, so nothing indicates thyromegaly, no goiters, no bumps, nothing like that. Now we're gonna go into range of motion, so I'm gonna have you do a couple movements. Go ahead and put your chin to your chest for me. This is normal flexion, 45 degrees, looks perfect. Now we're gonna do normal extension, so head all the way back as far as you can go. Normal's around 55 degrees, great. This next one is atlanto-occipital, so we're gonna do your ear to your shoulder, both sides, just your ear. Perfect. Normal for that is 35, and then rotation is just look one way and all the way the other way. Normal for this would be about 70. Great. And then the last one, a little interesting. You're gonna go to the side and then take your ear down, ear to chest. Perfect. And normal for that would be 40. Any pain when doing any of those motions?
No.
Okay. No tenderness, no pain, nothing like that. And full range of motion for the patient. Next up, we're gonna go ahead and palpate. For the neck area, we're gonna do the trachea, and then we're gonna do all of the lymph nodes. I'm gonna do the trachea first just because it's easier. I'm gonna go ahead and just, with my first finger and my thumb, I'm just gonna go up and down and just make sure everything is midline, nothing too aggressive. Good. Any tenderness, pain? Good. Now for our lymph nodes, I'm just gonna use the pads of my fingers and do almost like a tapping circular motion. You're gonna tell me if you feel pain or tenderness, and the things I'm looking for are lumps, nodules, any hardness and things like that that would be of concern. In front of the ear, I'm gonna start with his preauricular. Moving behind, we have the postauricular, occipital, tonsillar. Then we're gonna move the neck, and you have the submandibular, and then the submental. Okay. Next, we're gonna do the posterior and anterior triangle. I'm gonna kind of just use the sternocleidomastoid as my landmark and just, not really dig, but just go back and forth. For the posterior neck triangle and then the anterior neck triangle in front of the sternocleidomastoid. Next up is gonna be, I'm gonna feel his clavicle, and above is gonna be supraclavicular. And then underneath is the infraclavicular. Next up, I'm gonna do your arms. And we're gonna do the epitrochlear, and it's, for visual purposes, it's like right, this is the elbow, and it's just like a little bit above that. And again, I'm gonna do it bilaterally. Okay. The next one that would be tested would be the inguinal. Video purposes, I'm not gonna do it, but it would just be right by the groin area. And then the popliteal is just right behind the kneecap. Okay, no tenderness, no nodules or anything felt like that. I'm gonna go ahead and wash my hands. Next up, I'm gonna grab my stethoscope, and we're gonna listen. First thing I'm gonna listen for is the carotid arteries, one on each side. I'm gonna do one at a time. And for this, I'm gonna be listening with the bell. If I were to hear a brewery, it would be picked up with the bell because it's a low pitched sound. What I'm gonna have you do is breathe in, breathe out, and hold it, and I'm gonna listen. When I take it off, breathe regular, and we'll do the same on the other side. No bruits are noted or present, which is a normal finding. Over the thyroid, I'm going to have you stand up. Thyroid, we're going to assess and palpate from behind. So I'm going to have you actually face the camera. And what I'm going to do is just gently kind of like feel basically the Adam's apple and go a little bit back and under. And I'm going to have you go ahead and swallow. And what you feel for is the rise and fall in the thyroid. Go ahead and take a seat for me. If it were enlarged or anything that would be of concern, I would listen the same way I listened for the carotid arteries with the bowel and listen for a bruit, but since he has no thyromegaly, no signs, we're gonna go ahead and skip that part. Next up, we're gonna do your ears. Okay, Jane. First thing I'm gonna do is just inspect them. They're bilateral, equal in size bilaterally. And then the degree, they're like positioned at 10 degrees to the skull and normal set. Those would be certain conditions. If they were too low or too high set that you'd want to investigate, see what their history is. The pinna is this outside kind of folded area. You just want to make sure that it's well formed. I don't see any lesions, no deformities or anything like that. Everything with the skin color is appropriate to his ethnicity. For the external auditory canal, I'm just gonna take like a quick little peek, see if I see any like discoloration. We don't really have the best material here to complete the otoscopic exam, but I'll talk through it and just kind of mime through it basically with the pen light. What I'm looking for with the otoscopic exam for an adult, I'm gonna pull up at his ear and away at the pinna. For a child, I would pull down and back, and that just helps me visualize the tympanic membrane. What I'm looking for is to see that the tympanic membrane is present, bony prominence, bony landmarks basically, and then the light reflex. So first thing I'm gonna do is pull up and away, and I'm gonna look in one side, look in the other. Both sides, I have the tympanic membrane as like a pearly gray, transparent, no deformities present. Bony landmarks are also visible. And then on the right, this is your right side, I'm gonna look for the light reflex. Normally it should be at 5. Again, don't have the appropriate equipment, so we're kind of guesstimating. And then the left side should be about 7, at 7 o'clock. With the ears, we would also test hearing. We already did this with the cranial nerve assessment, so I'll just talk through it real quickly. But the whisper test, I would have him close one ear, whisper, he would repeat. They would do gross hearing. If that was appropriate, then we could just move on and not have to do any more tests. If something was wrong, you would do the tuning fork, the Weber test and the Rene test. Weber test would be strike the tuning fork on top of his head for localization. If you were to on one ear versus the other, that would be a sign of concern. And then the Rene or Rhine test, strike the tuning fork, put it on the mastoid process, take it off once he stops hearing it, and then put the tuning fork close to his ear but don't touch it. He should still be able to hear it. That shows that ear conduction is longer than bone conduction, and that would be a normal finding. For palpating the ears, I'm just gonna go ahead and kind of like lightly pinch everywhere. You're gonna tell me if you feel pain. I'm first gonna go over the pinna, down to the earlobe, anything?
Nope.
And I'm gonna go inside on that fold, and I'm gonna do the tragus. Still okay?
Mm-hmm.
And then the mastoid process, I'm gonna go from behind. All good.
Yep.
I don't feel any deformities. He doesn't have tenderness. Next up, pen light again. We're gonna do the nose. First, I'm gonna have you occlude one nostril. Breathe in, breathe out. Next side. Perfect. So the nostrils are patent bilaterally. Then I'm gonna flash my pen light and just take a peek. I'm looking at the mucous membranes, turbinates, septum, things like that. And from the looks of it, everything is pink, moist, and intact. Mucous membranes are great, pink, moist, intact. Turbinates as well. And then there's no edema present on the turbinates. And for the septum, that's where you could like see the deviations or like a clogged nostril basically. His is midline, no deviations, no perforations. No runny nose, so no rhinorrhea noted. And then, still with pen lights, for your lips, your throat, everything like that. Looking just on the inspection, lips are pink, no cracks, everything looks moist and good. Again, appropriate for his skin color and his ethnicity. What I'm gonna have you do is go ahead and pull down on your, and then pull up. Okay, just looking at the gingiva, everything is pink, moist, no deformities, no lesions. Go ahead and open your mouth for me, just regular. Okay, looking kind of at the cheek, like the buccal mucosa. Everything is pink, moist, no lesions, no protuberances, nothing like that. Stents and ducts are not injected, not distended. Having them pulled down, I looked at the gums, the gingiva, everything is pink. No hyperplasia, nothing too puffy. For your teeth, go ahead and smile for me. Do you have anything missing? Any loose teeth?
No.
All dentition is normal. For counting and numbering, and naming, what side is your right side? I'm gonna start on his right side. I'm gonna go from upper right, and it's gonna be 1, all the way over to the left side, which would be 16. Down would be 17 to 32. So a normal adult has 32 teeth. So from right to left, left down, left, back to right. And then the order of the teeth, I would have on the eye. Everybody would have molars in the back. Then you go to your premolars right in front of them, canines, and then the ones you see mostly are your incisors or your canines, basically. Now I'm gonna have you do open your mouth, stick out your tongue, and say ah.
Ah.
I'm noticing one more time.
Ah.
I'm looking at his soft palate and his hard palate. Everything is intact, pink and moist. And then I saw his uvula. It sits symmetrical. It sits midline, I'm sorry, and then it rises symmetrically. There's no deviations or concerns there. His tongue is symmetrical, pink, moist, no lesions. And then the floor of his mouth, I'm gonna have you lift your tongue up and then down. Okay. There are no lesions, no concerns, no deformities. Everything is moist. His frenulum, the little connector underneath the tongue and the lip, everything is intact. And then those Wharton ducts, they're normal, they're not injected. When I looked back at his tonsils, they were present, but not too big. I would give them a 2 out of 4, like 50% space between the pillars. They're pink, moist, no exudate, no white spots like stones or anything. And then his posterior pharynx, so all the way in the back, like the throat, what I see, is pink, not red. It's moist. There's no exudate, and I don't see any signs of postnasal drip. Okay, the next part of the assessment, we're going to do the eye exam. I'm going to start by just talking through the special tests listed because a lot of them we already did in the cranial nerve exam portion. So first one would be visual acuity. This would be testing his actual vision clarity. This would be with the Snellen test, Snellen chart. I would have him stand 20 feet away from the Snellen chart and read the line, the smallest line that is clear to him. If he wore contacts or glasses, I would let him wear those. And then another way you could do it is have the patient close one eye and read the chart as well. Another specialty test would be near vision, and that would be with the Rosenberg card. You just have the patient read like they're reading a book basically, and note the easiness or the not difficulty of reading the card. Another name for the Rosenberg card is the Jaeger card. And you want to make sure that they don't have to bring it up or like hold it extra far away. Another one would be peripheral vision. Again, that's for the seeing on the sides. That's when I would stand 2 feet away from him. We'd close one eye. He would say the numbers, or when I wiggle my fingers. And then extraocular motor movements would be the cardinal gauges. So make the H with my finger, make the star, and see that cranial nerves 3, 4, and 6 are intact. But like I already did those in the cranial nerve parts, we're just gonna go ahead and get into the inspection and palpation of the eyes. When I'm looking at his facial features, I'm going to just focus on the eyes for this part. And I'm gonna look at the orbital area. Make sure that his eyebrows are full, symmetrical bilaterally. Look at his eyelashes, make sure they're everted bilaterally, so just up and out. And then the palpable fissures, make sure that they're symmetrical and horizontal. What that is it's the upper eyelid and the lower eyelid, and I just want to make sure that it's horizontal and just all in line. His are perfect, normal, and fine. And then everything I'm looking at, everything is appropriate for his skin tone and ethnicity, like the hair matches his head. There is no edema, I don't see any lesions, and no discoloration or missing hair or anything like that. Next, I'm gonna look at the lacrimal apparatus. So this is that duct. It's like the literal tear duct, and it's at the most inner portion of his eye. I'm just looking at that, noticing if there's any redness, swelling, discharge. Nothing's present for him, everything looks good. And then now moving on to the eye structure itself. I'm looking at the conjunctiva, the sclera, cornea, iris, everything like that. So just starting off with the sclera, it's the white part. It's all white. I don't see any lesions, no red, no pop blood vessels, nothing like that, sorry. Conjunctiva is going to be just the coating over it, clear pink. Again, no lesions, no signs of infection or inflammation. I can ask you to kind of pull down on your eyes like this and look up. Pull a little more. I'm just looking, everything is pink, moist. There's no lesions down there as well. Cornea is going to be clear, round, without lesions. And then some tests for the cornea. You can do the corneal light reflex and the corneal sensitivity. I'm not going to do corneal sensitivity because we already did that with the cranial nerve exam, but this would be when I take like a cotton wisp or something and I touch, and you kind of have that blink reflex when it comes near. And then the corneal light reflex, very similar to what we did for Perla, but what we're going to do this time is instead of looking at me, you're going to look past me, and I'm going to shine the light in his eye, and what I'm looking for is the same light reflex on both eye, basically, or light reflection. And it's symmetrical on both sides. kind of like centered right by the pupil. For his iris and pupil, I'm looking at the color. His are like a blue-green, and they are round, circular. There's no bulging, no issues there. Perla we're gonna test now just because we're in the eyes, so that's pupils are equal, round, reactive, to light, and accommodative. Again, that'd be the eye, the light with the pen lights, and the pupils, make sure that they constrict. And then for accommodation, I would take my pen light and he would follow all the way to his nose and his pupils would converge. So that would be Perla. We already saw his was appropriate. For palpation, hand hygiene, I'm going to palpate the lacrimal apparatus. There's two parts of it, the duct and the gland. The gland should not be palpable, but the duct can be, and it's going to be in the lower orbital rim near the inner canthus, and I'm just gonna go ahead and palpate for any pain or tenderness. No. There's no discharge, no inflammation, nothing like that of concern. The last part of this exam would be the fundoscope exam. We already did that in the cranial nerve, so I'll just leave that for that. Next part of the exam, we're gonna be doing the chest and lungs. First thing we're gonna do is just the inspection. Normally what I would do with my patients is I would take their radial pulse, and as I am counting the pulse, I will also take notice of the respirations. For sake of the time of the video, listening for 30 seconds, watching for 30 seconds would not make sense. So I'm just gonna note that he is of healthy demeanor, and his respirations are 16. I notice that there's no accessory muscle use. He's not tripoding. He's not in any discomfort, so there's no discomfort with breathing, so it's regular and unlabored. Next, I'm gonna move on to just an overall look at his skin. Everything looks pink and appropriate to ethnicity. Another good way to know his oxygenation is his skin and his nails. What I'm gonna look at is the nail beds, and I'm gonna press down on his nail beds, and watch for the capillary refill, so watch for the color to return. I wanna see it within 2 seconds. Everything looks normal for him. I'm just gonna check the thumbs. Yep. Another way we could check for oxygenation is through clubbing. So I'm gonna have him put his fingers together and make sure there's a space in between. Everything looks good there. And then next we're gonna do like the size and shape of his chest and all the symmetry. We want to see normal contour, which would be the thorax is elliptical and symmetrical, meaning that I see under his shirt, but I see that his ribs meet his sternum at basically a 45-degree angle. He is normal and appropriate for his age, so everything is normal for him. And then the costal angle is going to be symmetrical and less than 90 degrees as well. The costal angle is where the edge of the rib meets the xiphoid process. Again, ribs to middle. Without a shirt on, it would be easier to see the venous pattern. If there's any abnormalities, kind of just a map work of all the venous network. Everything for him is normal. And then moving on, I would also notice any abnormalities. If he has pectus excavatum, kyphosis with the spine, scoliosis, anything like that, just knowing him, he does not, I would have him stand up and you could have him bend over and look and use the measuring tool, but there is no concern for him. So moving on, we're gonna go into palpation. I'm gonna go ahead and start with the trachea, and I'm gonna go on both sides. Just make sure everything is midline, nothing too aggressive for the touch, and everything, trachea is midline. Next we're moving on to the chest, and we're gonna do, you're gonna tell me if you feel any tenderness, and what I'm feeling for is masses. Crepitus will kind of be like bubble wrap almost, and then any pleural friction rub. Anything?
Nope.
Nothing is felt, no tenderness, no masses or crepitus is felt on my part. And then chest excursion, which is just chest expansion. It's when he's talking, when he's breathing. Want to make sure that it's at least 2 to 3 inches and symmetrical, so both sides expand and retract, which his do appropriately. And then tactile fremitus, I'm going to have you stand up. First thing we're going to do is face the camera, and at the angle of Louis, right over here, I'm going to start. He's going to say 99, and I'm going to go all the way down. A normal finding is that you feel the actual tactile fremitus here, and it's slowly going to start to diminish and fade. So go ahead and start with 99.
99, 99, 99, 99, 99.
Good, and then I'm going to have you face the window, and we're going to do the exact same thing.
99, 99, 99, 99.
Good. It's easier to feel in the back, but it still diminishes right around the area of the diaphragm, I would say. Okay, go ahead. Now we're going to do percussion. We want to hear resonance, so that air over the lungs. So I'm gonna just take 2 fingers and then like tap over, and you wanna hear a light resonance sound. So I'm just gonna start upper lobes and go down. And the lower you go, the more dull it gets. Okay, next thing we're gonna do is diaphragmatic excursion. So with this, posteriorly, I'm going to have him inhale and exhale, and I'm gonna do the test at the same time, and then not at the same time. I'm gonna do the same test, and then I'm gonna compare them. So first, I'm going to have you just inhale, and what's gonna happen is I'm gonna percuss. Okay, relax. I'm gonna have you inhale again. Okay, I'm gonna do it one more time, and like, wow, do a slow inhale, okay? Inhale. Great. Resonance is like more up here, and then I would guesstimate again, like the diaphragm area is where it gets dull. I'm gonna do the same thing. You're gonna breathe in, and then on your exhale is I'm going to percuss. Go ahead. Okay, same thing on this side. And it's the exact same thing. Resonance up here and then dullness down here. While I have you facing this way, I'm gonna go ahead and move on to the auscultation portion of this exam, and I'm gonna listen to his breath sounds. I'm gonna listen with the diaphragm, and I'm gonna go in a zigzag order. I want to try to listen to the upper lobes first, trying to be at the first and second intercostal space, and then move down appropriately. And then I'll try to get out periphery to get the bottom of the second and third lobe. Every time I touch you with the stethoscope, I want you to take a nice deep breath in and out. No adventitious breath sounds were heard. Everything was equal and clear to auscultation. I'm gonna go ahead and have you face the camera. And we're gonna do the exact same thing in the front. This one we're gonna notice, I'm gonna start up higher, and this is gonna be tracheobronchial sounds. This is the upper lobes and the upper bronchi. And then we're gonna get into the bronchovesicular. That's gonna be lobe 1, lobe 2, and the first and second intercostal spaces. And then we're gonna move down into the vesicular area, and that's gonna be like the peripheries, again, those lower lobes. Exact same thing. Again, no adventitious breath sounds heard. Everything is clear to auscultation, which is normal. And now we're gonna move on to the last part of the lung assessment, and we're gonna do auscultation of the voice sounds. I'm gonna have you repeat after me, say 1, 2, 3, 99 or E, and I'm gonna listen. Just for the sake of this, I'm gonna have you go onto the back side, I think. Perfect. The first one is gonna be whisper pectoloquy. And I'm gonna have you say 1, 2, 3. You're gonna just quietly say it, and I'm gonna listen.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3.
A normal finding for this should be muffled 1, 2, 3, and that's normal, so that's what I was hearing. And then the next one is bronchophony, and you're gonna go ahead and say 99. It should be very identical. It should be muffled and unclear. Is a normal sign.
99. 99. 99, 99.
Okay, and then the last one is the egophony, however you say that. And you're gonna go ahead and say E. I wanna try to hear E, even if it's muffled. If you hear A, that would be problematic.
E, 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 E.
Okay. Again, everything is as expected and normal. There is no adventitious breath sounds, no abnormalities noted. That concludes the lung exam. Okay, next part of the assessment, we're just gonna do like a quick snip and then I'll actually get to the heart and lungs, or the heart assessment. But first we're gonna do for jugular vein distension. And I have my patient positioned elevated 30 to 45 degrees, and I'm gonna look for jugular vein distension. What I'm gonna do is look at like the angle of Louis and right in front of the sternocleidomastoid and look for any distension and pulsations. Normal should be 2 to 3 centimeters. If it would be greater than or equal to 4, we would have pathology. His is normal 2 to 3, and then if we could do this way just a little bit. Perfect, same thing, 2 to 3. Next, we're gonna do the hepatojugular reflex. With this, I'm kind of just gonna like put mild pressure over his abdomen. With this, we should see distended internal jugular, external jugular, and then during like the first cardiac cycle, and then when I release the pressure, everything will go back to normal. Actually, he's also gonna be supine, so I'm gonna remove your pillows. Okay, thank you. And I'm just gonna do a little bit of pressure on your abdomen. Just breathe normal. And I'm looking for the distension, and I see both. And then I'm gonna go ahead and release. And you see everything go back to normal. I'm gonna get him on the table and then we'll be back. Okay, continuing the heart exam, I'm gonna go ahead and just do inspection first. Similar to the chest exam, we just wanna make sure oxygenation is appropriate. So I'm gonna look at his skin, the lips, the nails again. I would do capillary refill, press down, make sure it's less than 2 seconds. For precordium for pulsations, I want to make sure that there's no pulsations over the precordium, no pulsations over the osculatory areas. So what I'm gonna do is I am going to feel for the aortic, all the heart spots. So aortic, pulmonic, herbs, tricuspid, mitral. And I'm just gonna go ahead and feel for all of them, and I don't wanna feel pulsations. So aortic is the second right intercostal space on the sternal border. Pulmonic is the second left intercostal space on the sternal border. Herbs is third left intercostal space, left sternal border. Tricuspid is fourth intercostal space, fourth left intercostal space, sternal border. And then mitral is the fifth intercostal space, fifth left intercostal space on the midclavicular line. Next, what I'm gonna do is palpate. So for precordium, palpate the precordium, so his chest, for heaves, lifts, and thrills. I just did that over the area, so if my hand were to physically come off his hand, I would see a heave, and you would feel a thrill, like the vibration. For auscultation, I'm going to go over the 5 areas previously listed. I'm going to listen to all of them with my diaphragm. Actually, can I have you face this way? I'm going to listen the first time with my diaphragm for high pitch sounds, and then my bell for low pitch sounds. Okay, so I'm going to do the aortic, which is the second right intercostal space. You can just breathe normal. And then we're going to do pulmonic, second left intercostal space, sternal border. And then I'm going to do herbs, which is the third left intercostal space, sternal border. Then I'm going to do tricuspid, fourth left intercostal space, sternal border. And then I'm going to do mitral, which is the fifth left intercostal space, mid-clavicular line. The mitral area is also the area of the PMI, the point of maximal impact. So I'm going to listen there longer. You get the best sound and pulse. And then everything with my bell. So aortic, pulmonic, herbs, tricuspid, mitral. There were no extra there were no extra heart sounds. S1 and S2 were loud and equal. No murmurs. Everything was regular rate and rhythm. I would say S1 was heard louder at the sternal border, and S2 was at the lower sternal border, and S2 was heard higher at the upper sternal border, which is normal. And then we're gonna move into the vessel assessment. Again, just inspect his skin, make sure there's no discoloration, no cyanosis, no, discoloration, I guess. And then I would do all of my pulses. A normal pulse would be graded 2 out of 4. 2 out of 4. You don't want anything pounding and you don't want anything thready or weak. So for him, I'm gonna do the temporal lobe, temporal artery. Again, that'd be up here like earlier. The carotid, you wanna do one at a time so you don't occlude the brain of all of its oxygen and blood. Okay. And then you're gonna go ahead and do the brachial. I guess I can do these at the same time. Sorry, bad angle. And then you're gonna go ahead and do the radial. So we have the radial by the thumb and the ulnar by the pinky. Radial by the thumb, ulnar by the pinky. The femoral would be very close to the groin. And the popliteal is behind the kneecap. Maybe I'll just do one. And then we have the posterior tibialis, which is going to be right behind the medial malleolus. Right, if you can see kind of in here. And then the dorsalis pedis is going to be on the top of his foot. Okay, everything is 2 out of 4. Directly from this, we're going to do the Allen's test. So with his hand, I'm going to ask him to make a fist. And what I'm going to do is I'm going to occlude both the radial and ulnar artery. And the hand should blanch. And I want him, once I release the ulnar artery, open your hand, sorry. And then I am going to let go and you see color come back. We'll do it again on this hand, if we can. So I will occlude both. Open your hand. I'm gonna release. And the color goes back. You wanna see for reperfusion, so that means the radial artery could be used for an art line and that there's appropriate perfusion. And then the next one is the Holman sign. This is for DVT. So I would have him lay flat, supine, sorry. And what I would do is I would take his leg and actually do some dorsiflexion. And then I would feel all down his calf to see if there's pain. Obviously we do this bilaterally, and you don't want any pain. And you sit up. Okay. Okay, sorry for the poor angle, but we're gonna go ahead and finish off with the abdominal assessment. First, I'm just gonna inspect the skin. We're gonna keep a shirt on for the purpose of the video, but to drape him appropriately, I would pull a blanket up to like the belt line and then open the shirt, take off the shirt so I could have everything visible. I would make sure that everything color-wise is appropriate, and note any type of scars, marks, striae, anything like that, and just note that it was there before we started. Nothing was due to the exam. For him, his whole color is appropriate, normal for his ethnicity, normal throughout the body. There is no signs of bruising. Worrisome signs would be the Colin's sign, which is the bruising, the ecchymosis over the umbilical, and then the gray Turner sign would be the ecchymosis over the flanks of the abdomen, so the sides. He has nothing, no scars, no bruising. Noticing, like if I get in line with him, it's a flat contour. I do see up and down motion with every breath, which is normal. No pulsatile motion is noticed. And then for his umbilicus, it's inverted. There's no hernias present, no protuberances, nothing like that. And it's midline as well. I'm gonna go ahead and listen. Sorry for my reach. We're gonna listen to 2 things. One is gonna be bowel sounds. For bowel sounds, I'm gonna use the diaphragm. I wanna hear high-pitched sounds of the gurgling. And then I'm gonna listen to the vascular sounds with the bowels. Again, low pitch for bruits. For bowel sounds, I'm gonna go ahead and start in the right lower quadrant and work my way clockwise. And I want to start in the right lower quadrant and stay there until I hear a gurgle and then move from there. I'm gonna have you put your arms at your sides. Normal active bowel sounds are heard, maybe a little hyperactive. And then I'm gonna flip it over to the bell and I'm gonna listen for the vascular sounds. The first one I'm gonna do is the abdominal aorta, which is literally right on the belly button. And then next I'm gonna do is the renal arteries, and that's above the belly button and just to the right and to the left. Just because you can't see, I'm gonna describe it. And then I'm gonna do the iliac artery, which is just below the belly button and to the right and to the left. And then femoral would be to the groin. I'm not gonna film that part just for the video's sake. So I'm gonna go ahead and listen right now. So first is the abdominal aorta, the belly button. And then the renal, I'm gonna go up and to the right and left. And then for the iliac, I'm gonna go just lower and to the right and left. Okay. No bruises are heard, which is normal and expected for him. Again, sorry. Next, we're gonna do percussion. Same thing with the lungs. I'm gonna take 2 fingers and just hit across. I'm gonna go over all of your chest first, and then we'll go into the specifics. We should be hearing timpani, which is that drum-like air sound. So I'm just gonna go ahead and start. Okay, now I want to go over the liver. The liver is going to be on my right side. It's your right, yeah. And typically the top border, the upper border is not palpable to us because of the protection from the ribs. So we can just guess like the nipple line, and I'm just going to go down. I'm going to start percussing, and as soon as I stop hearing it be dull, I'm going to say that's mid-clavicula or mid-nipple. I'm gonna say it's like 8 centimeters, and anywhere from like 6 to 12, I believe, is normal. And that's where I feel the lower border. When you stop hearing it be dull is where you hear where it's the lower border. And then if you were to take a deep breath in and out, you could see when the chest rises that the liver becomes more palpable, so it descends like 1 to 2 centimeters, which is normal. Now we're gonna go onto the left side and we're gonna do the spleen, and it's like around the 11th intercostal space on the side, but I'm just gonna percuss all over. Normally you should not hear the spleen. You should not have dullness just because of the placement. If you were to hear dullness over this area, you would be of concern. It would be of concern for splenomegaly. Nothing for him, everything is normal. And now we're gonna move on to the liver percussion. I'm gonna do the scratch test for the liver percussion. So what I'm gonna do is I'm gonna put my stethoscope with the diaphragm on the liver, and I'm going to, with my other hand, scratch. I'm gonna start down and go all the way up. Once I start hearing the sound more loudly, I'm going to assume that that's the lower border. And it's very identical to where I percussed earlier and stopped. So we're gonna go ahead with that location for being our lower liver border. Finally, we're gonna go into palpation. One thing I did forget, I kind of talked about it earlier, but it would be abdominal, like the belly button reflex kind of. And the way to test it would be like coming from the outside and going towards the umbilicus, and you would see like the twitch towards the stimuli. So one side and the other. It's hard to see with the shirt on, so we're not gonna do that. And now we're gonna go into palpation. We're gonna start, I like just continuing right lower quadrant and then going all the way around. And I'm gonna start with light, which is just 1 centimeter, and then we'll progress to deep, which is, I believe, like 5 to 8, 5 to 7. And when we do the palpation, I'm never gonna like dig and try to find something. I'm just gonna see what I feel. You're gonna tell me if you feel any tenderness. I'm just feeling for masses. I don't feel any abnormalities, any tenderness for you.
Nope.
Okay, we are going to go ahead and call out what we're palpating for. Sorry, one more time. So I'm gonna be in the right lower quadrant. Kidneys would be on like either flank side basically, and they're not palpable. I'm gonna go up and you can feel the lower border of the liver, no spleen, no nothing on this side. And then just to go deep, same exact motion, same exact findings. No mass is palpated, of no concern. Everything's normal. This concludes the assessment video. Thank you for watching.